Thanks for having me here, first of all. There was a presentation earlier today that talked about guidance, sailing, and tacking to a course. And similar, when we're really designing product, we need to look at the same thing. Now, most of you probably working with different vendors. You think we might have a rowboat or a tanker or some combination of the two. But really, it's that course and how committed we are to the course to get us there. So what are some of the factors? And from a background standpoint, I run the Americas business for healthcare IT for CareStream. So what does that mean? Sales, implementation, and support. So those are the areas. So I don't primarily own R&D, but certainly the constituents that make up that area is a large part of our global business and really a big influencer into how we design product. So what are some of the factors? One thing I'll say about going fourth, I think I am 4 out of 5. Most of the slides and most of the content's already been said. So the good thing is, there's maybe not something that's revolutionary here, but it's a different perspective. And again, designing and thinking through mobile devices, they're here. 80%, this is a study 15 months ago, 80%, actually 83% of physicians are using mobile devices. You'll notice the different devices out there. The iPad at the time was 29%. Study came out 3 months ago that said iPad now is 62%. So very rapid adoption. In this room, I would venture to say it's closer to 100%. Not going to try to out someone and say, raise your hand who doesn't have a smart device, but I would venture to guess that's probably 100%. So knowing that, how are we going to make sure our course is charted in the right direction? So one of the fundamental questions, to app or to not app? Do you design a dedicated application for a device? And if you think about it from a designer standpoint, Len used the, do we want to have people that are actually testers or developers? Well, you're going to need more and more dedicated developers, the more dedicated applications you design for each device that comes out. So it really depends on the use case. Dr. Hirschhorn talked about various users, right? Radiologist, clear user of the imaging technology. Primary user, our historic, very comfortable world, really our primary conduit for information. That has changed. Referring physicians through EHR adoption or EMR adoption, primary user of this information. And then finally, the patient. Yes, the patient that's out there. More and more, this is being driven right now of how do you get this to the patient. So really the decision tree, is it as simple as, yes, do an application, really look at the use cases. What we've concluded is really using a very lightweight viewer that can be more universal. And the key to it is you can't give up functionality. If you come out with something and say you're an iPad user or an Apple user, and you can't use like the 2-finger swipe or the blow up, if you can't use that functionality, all of a sudden you're extremely frustrated. That's one of the nice things about the GUI, about the UI. So how do you make your application that's maybe not a dedicated app, but still takes advantage of that type of user interface? So one thought to go through. Next, there's other design considerations. The speed, how you get this information to your respective, again, user, radiologist, referring physician, or patient will really drive the adaptation of it. If it's slow, it won't be used by any of the three. So it has to be efficient, hence the lightweight. Also easy to deploy. Alberto talked about, they have a portal. And in that portal, there's a lot of maintenance, we heard. How you have to actually talk to the customer when they say, listen, it's great that I have that portal and I can look at my image, actually in this case, look at the report, but I'm not sure how to do this. So how you deploy it is vitally important. It's no longer 5 or 10 or 20 dedicated PACS workstations. It's typically thousands within the referring community and then hundreds of thousands in the patient community. And depending on your environment, it can certainly be well over 1 million a year. So it's another design thought. The government, looking at not globally now, but just the US, but each government body in each country has mandates and directions. Here, the government has helped foster how we design product. Meaningful use, specifically meaningful use 2. Spent about 90 minutes on it this morning. Certainly not going to go through the legislation again. But meaningful use 2 is not about the core infrastructure. It's not about getting EMRs. It's now starting to use it. The term was used earlier today. How do we use it meaningful? But also the patients. The patient's 4-day response of information, access to their information, 5% of their information from a meaningfully used EMR. These are all critical things of how we're getting it to the patient. What's really the bottom line here, you notice I don't talk through all my slides, so please feel free to read them all afterwards. But really the bottom and the takeaway of this is when we design an application, it has to be easy to use. You're not going to be sending out applications, people, out to those 100,000 million patients and teaching them how to use it. It has to be very intuitive, again, or it won't be adopted. Talked also about ACA, the Affordable Care Act. And really there's 3 primary goals of this. And the nice thing is technology that's being developed in radiology, not just by Carestream, there's others out there, but technology that's developed by radiology imaging groups. How do we help patient satisfaction? How do we get better referring physician adaptation? And how do we reduce cost? Image sharing technology does all 3 of those. Reducing costs and CDs, you've heard about that certainly, but also increase patient satisfaction, as well as now getting the referring physicians more into imaging. It's a great example of already, I know it seems like sometimes the course is so far away, but there are real, and not just one case or one area, I mean across the country, real examples where we've made significant progress. Security. Len had it on his 3rd to last slide. Security is probably the #1 issue why we don't see more adaptation right now of this type of technology. 2 CIO forums I was at in the last 6 months, security was a full day. Who's responsible for it? Is it the vendor? Is it the organization, whether it's private practice and or the hospital entity, the enterprise? Third aspect is it's in the cloud. Who's the owner there? Bless you. So if we look at that, there's no one answer. This has to be collective. There's security measures that we as a vendor have to put in our product to be qualified for meaningful use. If you have a dedicated risk product, there's a whole section on security. Have to meet it. It's not a yes, no, maybe. It's yes or no. But when it gets into now some of the other security measures, there is more gray. Biometrics. I want to use finger. I want to use optical. All sorts of different technologies that are coming out of the commercial world. How do you get that into your product? A lot of it, if you're hospital-based, is being driven by your CIO. That's a primary point of contact for us when we're in there. What is your vision for security? Let's make sure we're aligned to it. At the same time, we as a vendor need to be very educated on it. Even if we don't resell RSA or other products that are out there, we certainly should be aware of it and be able to communicate that to the consumer. I have 2 examples here, and this isn't intended to be a sales pitch, although you did see I did have sales as part of my title, but this isn't intended in that vein. But again, to reinforce that every vendor has examples like this. Real world where this technology, this development that 3 years ago, 5 years ago, we weren't there. So in this particular, in Spires, it's in the United Kingdom, they have 37 hospitals, multiple outpatient clinics, and a lot of different PACs. Dr. Dreyer talked earlier today about, it's not practical, right, to rip and replace your EMR, might have multiple EMRs. It's not practical to rip and replace any of your IT solutions, especially when you have mass. So how do you get there smartly? How do you take advantage of things like image sharing, of consolidation, of getting the information to your referring physician without ripping everything out? Fundamental question that you really probably look through into that roadmap and that plan. The other is a much more, I'd say, more practical case. In Houston Imaging, they're really going after a marketing aspect. How do we gain more referring physicians? How do we get more loyalty within our patients? They rolled out a portal strategy similar to what Alberto talked about earlier, and showing not only images and reports to their end consumer. And it's really driven a lot of compliance. And they feel that their marketability is now enhanced within that marketplace. So, as I said, a lot of topics, I think, were told in different sections of the morning and beginning of the afternoon. Really, the thought process here for me is truly from a vendor standpoint, when we're sitting down with R&D, charting our course, what does 3 years look like? What does 5 years look like? We know there's going to be tax back and forth. Not tax, that's another thing that's 2.3% on all medical device manufacturers. We could talk about that another time. Tax back and forth as to how you get there, but you have to have a vision. And if the vision's not there and you're not nimble enough to achieve it, then it's really, it's something that for the end user, radiologist, referring physician, patient, will never get there. So thank you.